Hello and welcome to Best of the Day from the 50th annual meeting of the American Society of Clinical Oncology, meeting once more in Chicago. This is Tuesday morning, the final day of the meeting. It's been a wonderful ASCO meeting with over 33,000 attendees this year and a tremendous amount of science that's been presented. A lot of information on immunology in cancer, as well as many other aspects of oncology. And as long as we're talking about immunologic approaches to cancer, we have Dr. Jed Wolchuk from Memorial Sloan Kettering Cancer Center this morning to talk to us about melanoma, some of the advances in immunologic therapy, immune checkpoint inhibitors, as well as some updates on some of the BRAF mutant study. So, Jed, welcome to Best of the Day. Thanks so much for coming.
Good morning, Jim. Thank you for having me.
So, it seems like the past 3 years in melanoma have been phenomenal. 3 years ago at Best of the Day, I sat down with John Kirkwood and reminded him that as far as the Chinese calendar was concerned, it was the year of the rat. But after having attended ASCO, we all knew it was actually the year of the mole, the malignant mole. And the malignant mole has been hanging around dramatically for 3 years now. A lot of it initially was the BRAF inhibitors and then the Mech inhibitors. And a couple years ago, we began to hear about anti-PD-1 monoclonal antibodies and then anti-PD-L1. And there was much, much more about that. But even before all of the PD-1 and PD-L1, there was Ipilimumab, and Ipilimumab, the anti-CTLA-4 monoclonal antibody, has been around for several years. It's been used extensively in advanced disease. But Lex Egermont presented a very large trial at this year's meeting looking at the role of Ipilimumab in the adjuvant setting, resected stage 3 melanomas, and patients were randomized to Ipilimumab versus placebo. How did that study work out?
So that study met its primary endpoint. It was, as you said, a large study, a phase 3 double-blind randomized placebo-controlled trial in about 915 patients with stage 3 melanoma who had all been surgically resected of both the primary and the involved lymph nodes. It was targeted toward the part of the stage 3 melanoma population that had a higher risk of recurrence, so less of the just few cells in the sentinel node population and more in the palpable lymph nodes or macroscopically involved lymph nodes. And that study met its primary endpoint in terms of relapse-free survival. It improved relapse-free survival by about 9 months. The hazard ratio was 0.75, and as Lex said yesterday, the p-value was highly significant. And so, despite the fact that the trial met its primary endpoint, it has caused us to ask some quite important questions about how to incorporate the data into practice as of Tuesday of ASCO. Right. And there are a few aspects of this study that I think are worth a bit of discussion. Well, first of all, by disclosure, I was one of the investigators on the study. Right. And this study used a dose and schedule of Ipilimumab that is distinct from the currently FDA-labeled dose and schedule for metastatic melanoma. It uses over 3 times as much Ipilimumab in the first 4 doses during the so-called induction, and then it involves maintenance therapy. So it's much more drug for a longer period of time than for patients with metastatic melanoma. And what that results in is quite a high incidence of dose-limiting toxicity. About half the patients had to stop the medicine because of side effects. Now, this was not unexpected because of the nature of the side effects of Ipilimumab. And some patients just need more immune augmentation than others. So most of those side effects were manageable with the standard algorithms. There were, unfortunately, 5 drug-related deaths. And so it brings into question how you incorporate a medicine which does have the possibility of significant side effects into a population where some of the patients are cured already.
Right.
It makes us rethink the risk-benefit profile. And it makes me, as a member of the community of melanoma oncologists, think about how we need to more precisely risk stratify in this post-surgical adjuvant population. I think we need better tools to identify the population of patients who is at the truly highest risk of recurrence, not just greater or less than 50%, but the ones who are more than 90% likely to recur in the next few months. So that study is going to require longer follow-up for overall survival. It's also going to probably benefit in the next couple of years from the results of a second trial that's being run by the ECOG here in the U.S., which randomizes patients to the standard dose of ipilimumab versus the higher dose versus high-dose interferon to try to fill in a few more gaps in the information needed to really implement CTLA-4 blockade in the adjuvant setting.
Well, I hope that study gets good support, because it sounds like something that really needs to be done.
Right. So that study, fortunately, is almost fully accrued.
Oh, that's great.
I think it's aiming at somewhere between 1,500 and 1,600 patients. And as of the presentation yesterday, I think only 50 more patients were needed for that analysis.
So in a few years, we may have some answers.
I think we'll have more information.
Very good. But let's move on to the PD-1, PD-L1 axis. And it seems like there are at least two horses in this race. Merck's Pembrolizumab now, or MK-3475, and Nivolumab from BMS are both racing rapidly towards FDA consideration. There was a lot of data this year about the Merck drug, the 3475 drug. Tony Ribas did a sort of an analysis of pooled data of almost, I think, 411 patients, perhaps one of the largest phase 1 patient bases in the history of oncology. So bring us up to date on this agent and you know, what it has been doing in the phase 1 trials, what the impact of PD-L1 staining has been, and is it of any importance, and any other aspects you think are really interesting.
Yeah, so you're correct. This is quite a race that's going on, and it's very fortunate, actually, for patients that there are multiple agents in development right now, some of which are in late-stage clinical development, that look quite promising in terms of delivering on the promise of immunotherapy for durable regressions in a significant number of patients. You mentioned two of them, but there are several more that are also active in this population. So we'll start with the first one you mentioned, which is Pembrolizumab, which until recently was known as MK-3475. My colleague Tony Ribas did an outstanding job yesterday presenting the most updated data on truly what I consider to be the largest phase 1 trial in oncology, because when you include the lung cancer patients, there are more than 1,000 patients on this phase 1 trial.
Unbelievable.
And the data this year was quite supportive of the initial information that was discussed last year at ASCO, really showing that there are quite significant number of responses. The response rate, depending upon the dose and schedule, can range a little bit between 30 to 40%. And these responses are, in Tony's estimation yesterday, 88% durable. Which is really what we want to see. Of course, we'd like to see 100%, everybody would, but this is a truly impressive number of patients who have disease that gets under control and then stays under control. The median overall survival for that population was not reached. We of course look forward to further analyses, but a very significant number of patients alive at 12 and 18 months. I believe 69% of the patients alive for a year and 62% for 18 months. Very impressive for, in this population of melanoma patients, which, as you said earlier, the malignant mole, as you called it, was a very frustrating clinical situation. But now we have not just, medicines that can palliate, but medicines that can control this disease for a very long period of time.
So these are the sort of durable responses that we used to see with high-dose IL-2, without all the toxicity and with a much higher response rate.
That's exactly right. I think we're seeing this in the outpatient setting without the capillary leak syndrome that can accompany high-dose IL-2, and in many more patients. You did bring up the most talked about biomarker for PD-1 and PD-L1 blockade, which is expression of the PD-1 ligand on the tumor cell. And this has been spoken about for several years. And there is really no doubt that patients who have tumors that express PD-L1 are more likely to have a response. But this is not a binary, static biomarker. It is not predictive in a yes or no fashion. And I think this needs to be made abundantly clear that there are patients whose tumors do not stain for PD-L1 who can respond to both PD-1 and PD-L1 blocking antibodies. Because after the initial reports of the PD-1 pathway blocking antibodies, there was a rush among oncology professionals and patients to ask the question, does the tumor stain for, is it PD-L1 positive or not? In the same way that we talk about, is it BRAF mutated or not? These are very different kinds of biomarkers. One is static and genetically encoded, and that's something like a BRAF mutation. The other is inducible and heterogeneous, meaning the PD-L1 expression. A patient's tumor can be PD-L1 negative one day and PD-L1 positive the next day. A little bit of inflammation comes through, induces some interferon. Interferon gamma can induce PD-L1 expression, and the tumor can then be PD-L1 positive. So we really cannot develop the mindset that it's only patients whose tumors express PD-L1 who will benefit. They are more likely, but I think that is an indicator of a more complex biology, where it's not just the interaction between the T cell and the tumor cell, but there's an interaction between the T cell and the antigen-presenting cell, right, which can also express PD-L1 that is important in the clinical benefit.
So is there any thought in tumors that have very low or no expression of PD-L1 to prep them with a PD-L1 inducing agent before giving them an antibody?
So this is a great question, and we're working on such strategies in the laboratory. In fact, one of the ways that has been thought about is, well, what if you gave anti-CTLA-4, ipilimumab? And as you know, there's work from a trial that I've been leading with Mario Schnoll at Yale, looking at the combination of ipilimumab and the other PD-1 blocking antibody nivolumab in patients with melanoma. We can talk about those in detailed data later, but that's really one of the theories underlying the additional activity, is that the introduction of ipilimumab may cause inflammation in the tumors, which causes them to become PD-L1 positive.
Is there any correlation between PD-L1 expression and durability of response?
There doesn't seem to be.
Okay, that's very interesting.
Yeah.
All right, well then let's move on and talk about nivolumab then. And you mentioned the study that you and Mario Schnoll are involved in, looking at either concurrent or sequential. And the data that presented this year mainly had to do with the concurrent population. But tell us again a little bit about the rationale for combining these two agents, both active immune checkpoint inhibitors, but ipilimumab brings a lot of baggage with it.
Right. So I think the rationale is strong from the preclinical side. In animal models, the provision of both antibodies does significantly improve tumor regression rates in animal models of both colorectal cancer and melanoma in mice. There is also just a recognition that these are both critical, non-redundant immune checkpoints that don't follow the same route to the end of T-cell activation. In addition, one of the findings that supports the combination is that one of the earliest findings after a T-cell sees anti-CTLA-4 is that it upregulates PD-1. So the immune system, says, okay, you're going to cut off this inhibitory pathway, I'm going to start using another one. And now we have two ways to intervene to allow for more robust activation. So based on that, we launched a phase 1 trial several years ago combining escalating doses of nivolumab with the standard dose of ipilimumab concurrently at first. And we presented last year at ASCO that overall, across all dose levels, the response rate for the combination was 40%. An impressive number of those patients actually developed complete or near complete responses in a very rapid fashion. In fact, in the dose level that was selected to move forward into phase 2 and phase 3 trials, which have subsequently completed accrual, which is 3 milligrams per kilogram of ipilimumab, 1 milligram per kilogram of nivolumab, the response rate was 53%, with all of those patients demonstrating a greater than 80% decrease in tumor burden by the first time we looked. And so this was uncharacteristic of the responses to immunotherapy that we had seen with single antibodies in the past. You did bring up the fact that it's important to note that there were more toxicities with the combination than with either one alone. And that's somewhat logical because we're bringing two medicines together that have distinct patterns of side effects. They're immune-related side effects, but they're different. And so we see more patients with multiple side effects than we did before, but most of these side effects can be rapidly controlled with the algorithmic use of immune-suppressing medicines. And we feel comfortable with the risk-benefit profile of this combination.
Because there was like over 50% grade 3/4 adverse events.
There was actually up to 62% this year with the additional 41 patients treated at our site and 2 others.
And with the anti-PD-1, it's more like 10-15%.
It's quite a bit lower. The PD-1 blocking medicines by themselves really have quite a low incidence of side effects. One of the major contributors to that large number of grade 3 and 4 toxicities are asymptomatic elevations of amylase and lipase, which really most of the time do not require any intervention at all, are not indicative of any type of clinical pancreatitis. We've looked, obviously, both symptomatically and also radiographically. We're not sure what it really means, but we follow the rules of the protocol, and we have to call them what they are.
Right. Very good. And then what about the follow-up data on some of the ongoing nivolumab studies? I mean, this has been going on, especially in patients who've never been exposed to IPI.
Right. So, the nivolumab data was presented by Steve Hody, and again, the story looks quite similar to with MK3475 or Pembrolizumab, where we're seeing patients who have durable responses, even patients who had to stop treatment for some type of side effect. The responses are durable even if you have to stop treatment. And I think that the types of median survivals that are being seen, in the nivolumab population are very impressive compared to what we had experienced in the past. You're looking at numbers in the 17 to 20 month range, depending upon the dose cohorts, which is amazing when you think about the fact that it was only a few years ago, before 2010, before BRAF inhibitors and ipilimumab, that the textbook answer to that question was, 7 to 8 months was the median survival for melanoma patients.
So in patients who have stopped the anti-PD-1, anti-PD-L1 antibodies, is anyone looking at changes in the T-cell population in these patients, whether CD4, CD8 go up and come back down, or what's going on with their T-cell population? Right.
So I think that's a matter of much ongoing research, is identifying mechanistic biomarkers and changes in phenotypes of T-cells that occur after PD-1 blockade. I think this is just going to require more time.
Very interesting.
Yes.
Well, let's talk a little bit about the small molecule inhibitors, and we'll get some updates on the BRAF mutant patients. But there are a couple new areas that I noticed we're looking at. There are across a number of fields. There's a lot of studies looking at CDK4/6 inhibitors. There was one presentation on LEE-011, which I think is a Novartis product. And then we've also seen data with Mech Inhibitors in the BRAF mutant. But the combination of a CDK4/6 and a Mech inhibitor, what is the scientific rationale for that combinations? And How does that look?
I think that there's strong scientific rationale for really silencing that MAP kinase pathway as definitively as possible. And knowing that many melanoma patients, for example, can also have aberrations of that CDK4 pathway as well, really forms a strong rationale for that combination. And as you know, targeting RAS has really been a major challenge, not just in melanoma, but there are many different cancers that have oncogenic driving mutations in RAS. And there was, in fact, one pancreatic cancer patient with a KRAS mutation in the LEE plus Mech work that was presented by Jeff Sossman, and we are seeing clinical activity from that combination, and I think that the audience and the community of oncologists are enthusiastic about seeing this combination move forward. Getting more patient experience. It's still early days, but I think it was very important to share some enthusiastic news that we finally do have medicines that can at least dampen this very, very important RAS pathway.
Any unusual, unexpected adverse events that's come up? I mean, we're used to seeing fatigue, rash, diarrhea in a lot of these small molecule inhibitors.
I mean, I don't think there was anything unusual. I think everything that we saw could either be attributed to the disease itself in some cases, or to kind of an expected side effect. I believe, and we may want to just pause for a second, but I believe there was one cardiac event in that study.
Something to watch.
Yeah, something to watch.
Very good. Well, let's talk again about the BRAF mutant, and we've watched this story evolve for a number of years now. We've seen the squamous cell cutaneous problems, like keratoacanthomas and squamous cell carcinomas, and the very nice responses, but somewhat time limited, and then the GSK people added a Mech inhibitor, trametinib, to their BRAF inhibitor, dabrafenib. And there have been some studies looking at dabrafenib alone versus the combination. So bring us up to date on what has been happening with those trials.
Yeah, very important advances in that area. Again, there's one pathway that's very important for these BRAF mutated melanomas, which is the MAP kinase pathway. And we saw tremendous initial activity with just the selective BRAF kinase inhibitors, vemurafenib and dabrafenib. We also know that those are limited in terms of the time that the response is maintained. And one additional intervention that could be added is a Mech inhibitor as well. And it looks like more patients do benefit in terms of the response rates being incrementally higher with the combination. And both the PFS, the progression-free survival, and to a lesser extent the overall survival seem to be a bit longer. But I think we really need more data from the Phase 3, what's called the COMBD trial, which was presented by Georgina Long, to support how big that incremental benefit is, especially in overall survival, because it looked like the patients treated with dabrafenib alone in that COMBD study did better than the dabrafenib alone population that was in the Phase 2 trial, which was updated by Keith Flaherty.
That was my impression as well.
Yes, yes. And I think that you brought up an interesting point that the addition of the Mech inhibitor is not just an attempt to try to improve the clinical efficacy, but it does address an important side effect of BRAF inhibition, which is the somewhat rapid emergence of these keratinocytic neoplasms, the keratoacanthomas and squamous cell carcinomas, which can be a quality of life issue for the patient in terms of how frequently they need to have excisions. And the Mech inhibitor addition does significantly decrease that problem.
So I know with this vertical blockade of the MAP kinase pathway, people are also looking at ERK inhibitors.
Yes.
Is this going to be a step forward, do you think?
I think we need to have ERK inhibitors move out a little bit in terms of later stage clinical trials. There have been some early studies, nothing really reported yet that I'm aware of in terms of a significant experience with ERK inhibitors in melanoma, but that's another step. And in addition to being important in BRAF-driven melanomas, melanomas. ERK inhibitors could also help with RAS-driven tumors as well.
So if we shut down MAP kinase, is that going to upregulate the PI3 kinase AKT-mTOR pathway in compensation? And if we shut both pathways down, what kind of adverse events are we going to get?
Well, I think time will tell, but there are already, trials ongoing of combined PI3 kinase and MAP kinase pathway inhibition out there. We just need more time.
Very good, very interesting. Jed, thank you so much for coming
Thank
by.
you,
I
Jim.
know, I don't know if all of you realize this, but Jed is also the chairman of the Scientific Program Committee for ASCO this year. So he is probably the busiest person in Chicago this weekend. And we really appreciate your taking time to be with us.
Well, thank you, Jim. It was a great pleasure to share this important information with the audience.
Very good. Thanks so much. And thanks to all of you for watching this segment of Best of the Day from the 50th annual meeting of the American Society of Clinical Oncology. There is more to come today in lung cancer and GI malignancies, and then we have already videos on the web in many other areas from this year's meeting. So be sure to check on those. Thanks again.